Well, we have been very involved in Zika research. We started in February of this year, and we have projects ongoing both to study the natural history of Zika infection, and also at the Hope Clinic we're performing a vaccine trial, a Zika vaccine trial. There's so much to be learned right now. And so in humans who are returning from travel, we have an NIH-funded study for return travelers, U.S. travelers who become ill, to study the natural history of Zika. And so we look at the levels of virus in various body fluids. We do their clinical histories and physical exams. And then we also study the immune responses, T cells, B cells. And we've now got pilot data on about 15 patients, and the formal NIH study is starting and has started, and we've probably seen about 40 or more patients at the Hope Clinic who have Zika after returning from travel, generally to Caribbean, South America, Latin America, Mexico. And it's been very fascinating to be involved in this research. It feels like we're beginning to understand a bit more. There's so much that needs to be learned. All of the point of all this is, of the natural history studies, is to get fundamental information about what's going on with Zika infection to help us better design and develop what are called countermeasures, which are vaccines, treatments, and diagnostic tests. And these are three areas where there are many needs for Zika right now. So the patients we've been enrolling are residents of the state of Georgia who have traveled to a Zika epidemic area. We then ask them if they'd like to help us fight Zika, and it's been very gratifying. Many of the patients are really wanting to help out because they know that there's so much more that needs to be done. And of course the big driver for all of this is pregnant women and babies, and trying to protect the fetuses developing in pregnant women. So we found that these patients who have come back from their travel to home to the Atlanta area are very willing and interested to help out in this research. So countermeasures, really I think of it as four things. One is we've got to develop fundamental knowledge about the human Zika infection. Two, we need vaccines. Probably most important for vaccines would be a vaccine to protect women and pregnant women. And really we need to vaccinate women before they become pregnant. So it might be a pre-pregnancy vaccine, because you don't want them to get infected during the first trimester, especially when it appears that the greatest damage can occur. Although Zika infection at any time during pregnancy may result in some birth abnormalities, unfortunately. Ultimately, once we have a vaccine, it might be that initially it would be rolled out for the highest priority group, pregnant women, their sex partners. And we've got to start thinking about Zika as a sexually transmitted infection, because we know it can be transmitted sexually. And then later, when vaccine supply is larger, potentially a vaccine could be rolled out to the entire populations of endemic areas or epidemic areas. This is what was done in the U.S. back in the 60s for rubella. At that time, congenital rubella syndrome was a real problem. For example, in 1965, 50,000 pregnant women in the U.S. were exposed to rubella, and 20,000 of them had babies born with the congenital rubella syndrome. So the highest priority countermeasure is a vaccine, I think. And the second would be treatments, and that includes monoclonal antibodies, antiviral drugs, and these again might potentially be useful for women who are either considering pregnancy or are already pregnant, as prevention or treatment to keep them from getting Zika, or if they have Zika, to try to reduce the viral load. Key thing for both vaccines and therapeutics would be to reduce the level of virus in blood to try to not have fetuses get infected from their moms. And the third and final countermeasure area are better diagnostics. Right now we have the molecular assay, the PCR test, and that's positive in serum or plasma just for the first 7 days. It can be positive in urine for up to 14 days, but we need a wider window and maybe a more sensitive molecular test for diagnosis of acute infection. Serology is very difficult, antibody tests, particularly in areas where there's a lot of co-circulating dengue. And that's because they're both flaviviruses. Dengue and Zika are cousins, about 50% amino acid homology in the E or surface protein of the virus. And so antibody tests from sera from those areas, there's a lot of cross-reactivity, and it can be very hard to distinguish Zika from dengue with antibody assays in the endemic areas. So we need better diagnostics, a molecular test that perhaps could be used for a longer period of time, or antibody tests that can discriminate between Zika and other flaviviruses.